Hi everyone, how's it going? It is Christina and I am doing tonight's journal club, so we're not waiting for anybody right now. It's just me. So before I get started, I just wanted to make a couple of group announcements. One is the Women's Psychiatry conference is over halfway sold out. Our goal is to get to around 150 attendees, and we're halfway there, more than halfway there. It's going to be great. We have lots of activities, lots of great talks. So if you have any questions, any concerns or special needs about attending the conference, just send me a private message or email me at psychiatrynetwork@gmail.com and I can help you out. The second announcement I wanted to make was just for you guys to keep an eye out for two sponsored posts that I put up today. One was for simpleandpractical.com by our very own Dr. Rajneesh Mago, who provides this great service, daily email, every day, 365 days a year, and we have partnered together to provide you guys with a discount code. So $25 off, a great refund policy, and lots of helpful information. I personally get the emails myself and I really enjoy them. And the other sponsored post that I put up is for a telepsychiatry company, Enzyme Health. They put doctors in touch with other companies who are hiring full-time and part-time telepsychiatrists. Right now they're looking for both part-time and full-time, and there is it's just adult psychiatry, no child right now, but if you're interested in that, just keep an eye out for that post. So I know telepsychiatry positions are always popular here. So and then thirdly, just a reminder to join our mailing list. It's Psychiatry Network, etc.com is the website, and you can also just email me directly at psychiatrynetwork at gmail.com, and I'm happy to add you to the list. So just for group announcements, events, and things like that. So okay, so with that, I am going to get started. Welcome to our journal club, and tonight I'm going to be presenting an article titled Physical Exercise for Late Life Major Depression. And I'm really excited about this article because I think anytime that we have something non-pharmacologic that shows some efficacy, that's great. It's another option for us to use. And so this is a really interesting study. It came out of Italy, and all the authors in this study, interestingly, are all different specialties. So there's psychiatrists who are authoring this paper, but also neurologists, geriatric internists, cardiology, and family medicine. And they did disclose that they get funding from a grant somewhere in Italy. So it didn't sound like anything pharma or anything sponsored like that. And so they start out with the introduction of the article, and they give you a little background on why late life major depression is so important to treat and to address. So we know that it's an issue because it causes suffering, it causes an increase in morbidity and mortality, and ultimately increases healthcare costs for society. I think they're talking about Italy, but we know that that's true here in the United States as well. And so currently our medication options for depression, and in particular late life depression, are not adequate. Medications are difficult to titrate very high in elderly patients. We know that. And then also the efficacy of the medications is not very good either. And so anything that can improve efficacy of medication or in and of itself improve depression is going to be something great. And so the authors propose, and there's been previous literature out there that talks about the possibility of exercise as a safe and viable strategy to augment and improve the efficacy of antidepressant drugs. So this has been proved. Hey, Katija. So this has already been shown in depression in adults, but it hasn't been shown in the past in geriatric patients. And so there's a couple of different theories about why this happens. One is that exercise can increase neurotrophic factors like BDNF, improves neurogenesis, leading to improvements in neurocognitive performance, and also reduces pro-inflammatory cytokines and the HPA, the hypothalamic pituitary. Okay, sorry, that was just a phone call from Kansas, probably spam. And also exercise counteracts disability. And social isolation, and improves psychological self-evaluation. So these are things that we already know about exercise. And so we have only seen this, like I said, in younger adults, but not in older adults. So their goal was to investigate whether the combination of sertraline treatment, that was the medication that they chose to use in this study, was combined with sertraline by itself, sertraline with two types of physical exercise. So there's three groups in the study. One was a higher intensity progressive aerobic exercise, and the other type of exercise was a lower intensity non-progressive physical exercise. And they actually do put the exercise protocols in at the end of the article that you can take a look at if you're really quite interested. So they wanted to know if that led to better outcomes in late life depression over 24 weeks than with sertraline alone. And so the study was done over 24 weeks, which is almost 6 months, which is great. And all the participants were between 65 and 85 years old. They all had a diagnosis of major depression. And the recruitment strategy that they used was based on getting patients from primary care centers where most patients with depression are usually seen and treated. And so the two different types of settings that they recruited from were university departments as well as community mental health centers. And so next part of the article, they talk about recruitment. How did they recruit these patients? So the recruitment phase was held by meeting with these primary care physicians to present the study, providing training on the diagnosis of depression and the selection criteria. And so they asked patients to screen for, they asked the physicians to screen for patients who complained of depressive symptoms and whose health status was compatible with regular exercise, meaning that they were not too physically frail to exercise. And so each center had contact with the study coordinators at least once every 6 weeks with the physicians, where they discussed the logistics of the study and scheduling of visits. As I said, everybody was age 65 to 85, and then they diagnosed major depressive disorder with scoring 18 or higher on the Hamilton rating scale for depression, which is the HRSD, which, by the way, I had to look that up because I was like, is that the same thing as the HAM-D? And it is the same thing as the HAM-D. Apparently, the HAM-D goes by both titles. And so they also wanted to make sure that the patients were initially sedentary, because if they were already exercising, too frequently, then they were excluded from the study. Other things that they excluded were Axis 1 diagnoses, other Axis 1 diagnoses, substance or alcohol problems, cognitive impairment, which was anything on the mini mental status less than 24, and then any significant physical illness. So like major cardiac issues, osteoarthritis, uncontrolled diabetes, heart failure, Parkinson's, etc. And so they initially would meet with the patients and then measure their baseline aerobic capacity. So, excuse me, I'm just flipping my notes. And measured a few other things. This aerobic capacity is just a 12-minute test where they basically just looked at things like muscular exhaustion. No, I'm sorry. They only stopped it for things like muscular exhaustion, etc. Okay, so then the next thing that they did was that they randomized and then masked. So this was a single blind study, meaning that The participants knew, of course, what type of exercise or lack of exercise they were doing, but the doctors, the clinical doctors, did not know. So the clinical doctors were just asked to treat their patients with sertraline and titrate it as they normally would in clinical practice. And we'll talk a little bit about the dosing and things like that, like how high they got. And so the number of patients that they had, 42 patients in the sertraline-only study, 37 in the non-progressive exercise study, and then, group, and then sertraline plus supervised group progressive aerobic exercise was 42. So the groups were not huge, but they were a fairly decent size. And I think that, plus the fact that it was 24 weeks, was pretty good. So sertraline, they started with a slow titration for all the patients, and the goal was to reach, the standard dosing was 50 milligrams within 2 weeks. And they chose sertraline based on its safety and efficacy in older patients, as well as its low potential for pharmacologic interactions. And I will say that sertraline is also one of my favorites for older patients because it's easier to titrate. There's less limitations with the QTC prolongation that we have to address with citalopram. Escitalopram, I think, is also a good choice, but looks like they decided to go with sertraline, which is a fine choice. And so they essentially said they could just titrate as needed with routine clinical practice. And then if the patients had insomnia, they allowed them to use zolpidem or lorazepam just for the first 4 weeks of the study, and then for the rest of the study they discouraged use. But they didn't say that they wouldn't allow it, they just said that they discouraged it. And so let's talk about the two different groups besides sertraline. So there's a sertraline plus non-progressive exercise, and then sertraline plus progressive aerobic exercise. And so the non-progressive exercise, they also received sertraline, and they were basically prescribed 3 supervised group exercise sessions a week, 60 minutes duration for 24 weeks. The groups were 3 to 6 participants per group. And these sessions were designed to improve patient strength, balance, respiration, and motor coordination, and were comprised of both mat work and instrumental exercises. And you can look at the appendix if you're interested in the specific protocol. And so they also used heart rate monitors with on-screen visualization, which might be fun for patients. And so they basically were assigned to exercise at specific heart rate ranges, and they were not supposed to exceed 70% of their heart rate, and so of their peak rate. And so if they did exceed higher than that 70%, they were asked by their instructors to reduce the intensity of their exercise so that they could get back into the lower heart rate area. Okay, so then the other group was this progressive aerobic exercise, which essentially they also received sertraline, and they also did 3 60-minute sessions a week for 24 weeks, 3 to 6 participants, and these were done on exercise bicycles. And so the goal was improving cardiopulmonary functioning. And so they would start with a 10-minute warm-up breathing exercise, followed by cycling at an intensity that was at least 60% of their peak heart rate. And so as the weeks progressed, they were asked to increase the intensity over time. And then they had a 5 to 10 minute cool down. Okay, so they did assessments at 4 weeks, 8 weeks, 12 weeks, and 24 weeks. And so they actually had psychiatrists who administered the mini mental status. They administered the HAM-D, obviously. And then there's a number of different I'm not familiar with all these, but just different activity questionnaire and some other things, a cognitive rating scale, etc. So they looked at a variety of different things. And so, and they also tried to have inter-rater reliability with some training. Okay, so next part was the outcomes. So the primary outcome of the study was the rate and time to remission from depression over the 24-week period, which is something to keep note of. Hi, SD Skoy. Okay, so they defined remission as a HAM-D or HRSD score of 10 or below. Remember, they were starting at scores of 18 or greater as a diagnosis of depression. And so secondary outcomes included changes in the severity of the depression, which just, they used the HAM-D for that, global improvement of depression, which was the CGI scale, and then changes in aerobic capacity. So those were the secondary outcomes that they looked at. The next section was statistical analysis, and I'm going to be honest with you guys, I always skip the statistical analysis part because it's just not my forte, and I assume that they did a decent job with their stats, but you're welcome to read that on your own if you're so inclined. Okay, so the results, which I think personally are the most interesting part of the study. So eligible participants were recruited from January 2011 to 2012. They had a total of 121 patients that entered the study. They did have exclusion criteria. If they were not depressed, they excluded them. If they had significant impaired cognition like dementia, they excluded them. Significant physical illness, active, like not sedentary, or if they just didn't want to participate. So there was about 56 patients that they excluded. So that brought them down to 121, and then they randomized to the three groups: the sertraline plus non-progressive activity, and the sertraline plus progressive aerobic exercise. And so the mean age of the patients in these groups was 75 years old, and the majority were women, which is interesting, or not interesting. I mean, if you work with geriatric populations. Most were not married, had elementary or lower level education, and the most frequent physical comorbidities were hypertension, musculoskeletal problems, and a couple of other things. The median HAM-D score for the whole sample was 18, and so they considered that mild to moderate depression. So that was the majority of people. And there was only one patient who had a history of significant suicide attempts. So most of these patients had been, pretty healthy psychiatrically prior to the study. And so they did have a few people that dropped out of the study, and it was kind of equal among the three groups. So it wasn't like one group had more dropouts than the others. And so mostly it was just people just didn't want to be in the study anymore. A few had new medical problems that started during the study. And then also one person needed a higher level of care for depression. And so they had common mild side effects to the medication. I'm not going to go through those. I think we all know what those are. And then they had a couple of things that were related to the exercise. So one had an ankle distortion is what they called it, and then one had worsening of musculoskeletal pain. And so those people had to drop out as well. And so by the end of the study, there were the sertraline only group ended with higher doses. So what they're saying here is that there's a couple of differences that they found between the sertraline only group and the two other groups, which were sertraline plus the two different types of exercise. And one was that the average dosing for the sertraline only group, the average was higher than, so they had to use higher dosing of the antidepressant if they were not doing the exercise along with it. And then the other thing was that the rate of non-adherence to sertraline treatment tended to be higher. And they considered non-adherence as missing 3 doses or more at a time, or 3 days in a row. If the patient skipped 3 days in a row, they were considered non-adherent. And so that was higher in the sertraline only group. So the patients who were exercising tended to be more compliant, it sounded like, with the medication. And then finally, the attendance at the exercise sessions, because we all think like, oh, we might, send patients off to do this stuff and then they're not going to do it. But in this study, the attendance was high, so 70% for a total of 72 sessions in each of the groups. So, and it was similar in both types of exercise groups. all the groups tended to drop off with the exercise after, or both groups tended to drop off with exercise after the study was over and during the follow-up period. Okay, so how did depression look after the study was over? So like I said, they looked at 4 weeks, 8 weeks, and the numbers at 4 weeks and 8 weeks are pretty interesting. And then we'll also talk about the numbers at 24 weeks. But at 4 weeks, the rates for the sertraline only group, remission of depression was 7%. The sertraline and the non-progressive exercise was 40% remission rate. And then the sertraline plus the progressive aerobic exercise was 36%. So the two exercise groups at 4 weeks had a significantly higher rate of remission than the sertraline only group, which is fantastic because a lot of times we start patients on a medication and 4 weeks later they're still not better. But the numbers for the medication plus exercise groups sounded pretty good to me. And so at week 8, the rates were 40%, 49%, and 60%, respectively, to the groups that I mentioned before. And then by the end of the study, remission was achieved by 45% of the sertraline only group, which is, I think, consistent with previous studies. 73% of the sertraline plus non-progressive exercise group, and 81% of those in the sertraline plus progressive aerobic exercise. I have never really seen any study that has an 80% remission rate of depression. So I thought that was really noteworthy, I would say. And they did adjust for confounders to see, were there other potential reasons for some of these outcomes, and they really didn't see a difference even after they adjusted for some of the study factors and some of the clinical factors. And so the changes in depressive symptoms is the next section. They noted that there were greater decreases in the HAM-D scores in the two exercise groups compared with the sertraline only group. And we can look at the specific, I don't think we need to look at the specific HAM-D scores, but just know that the depressive symptoms improved more in the exercise groups. And then the changes in aerobic capacity also showed, and this is obviously expected, but aerobic capacity increased the most in the progressive exercise groups, a little bit less in the non-progressive group and the sertraline only group. Okay, so let's see. They then talked a little bit about. So in the discussion portion, they talked a little bit about how their findings differ a little bit from previous studies. So they have the previous studies just didn't have as robust findings, but there's reasons for that, like maybe the type of patients that they picked. One study picked patients with non-major depression, which I guess is minor depression. And so the previous studies didn't have as strong of findings. And so they kind of conjecture that maybe that they have more robust findings than these previous studies because of the fact that they used an antidepressant drug. Previous studies would just test exercise for older patients without using a medication. So that was one difference. And then also social support due to exercising in the groups. So they did group exercising. They also had more intense exercise protocols and a longer duration of interventions. And so and then they also noted that there was one study with escitalopram plus Tai Chi and meditation that did have some good findings. And I think that's all. I think that's worth noting. Study limitations was that they did not have the main one is that they didn't have an active comparator, such as a social support or health education group meetings as an augmentation to the sertraline only strategy, but they Essentially, they did that purposefully for several reasons. One of them being that we already know that SSRIs are beneficial, and so they are beneficial, but they don't work completely. And so I think they didn't want to add anything that would change what that looked like. And then also knowing that physical exercise is already shown to be more effective than a social group program. And then the third one was they didn't want to increase the frequency of things, which would lead to higher dropout rates. And so they said that despite randomization, they observed some imbalances between baseline patient characteristics, but that did not affect their results. And finally, they said that, well, maybe that this would be a problem, like our findings may not be generalizable to a broad population of elderly patients if they're including individuals that aren't recognized by their physicians as depressed. So that has to happen before this could be applied to a patient. And so last section is the clinical implications. And so they wanted to basically summarize that it's noteworthy that nearly 3/4 of the patients who received physical exercise as an add-on to sertraline reached remission within the study period. And that was far higher than those who received sertraline alone. And then remission was faster than is commonly seen with just antidepressant treatment in elderly patients. And so the patient population that they used were essentially representative of sedentary patients with late life major depression who are usually encountered in primary care. The vast majority had been treated with an antidepressant in the past, but had side effects or not great responses to the medications. And let's see, I think essentially they conclude that physical exercise is a great augmentation strategy and is more effective than antidepressant use alone in older adults with major depression who are sedentary. And so this might be a great option for something that you can add to your treatment strategy. And I will say, if you guys are like needing some motivation to go to the gym, I think this is a good study to do that. You don't have to be over 65 or depressed. I think it's just really, I think, not heartwarming, but I thought it was really nice that these older patients are all agreeing and then participating in these exercise groups. And so I actually went to the gym the last couple of days, and I was looking around and noticing that there's, especially during the daytime, there's a lot of like older patients at the gym during the day. So I think that that's great. We're probably not seeing these patients as much in the hospital because they're healthier at baseline, but if you're seeing them in an outpatient setting, I think it's worthwhile. It's a worthwhile strategy. And so for anybody, if you guys have any questions, feel free to post them. Otherwise, I'm going to wrap up the video. Just remember that you can get free CME for watching this video, and I put the link to American Physician Institute at the top of the post. As always, if you want to join the mailing list, feel free to do so. It's just email me at psychiatrynetwork@gmail.com, and I will be happy to add you. All right, everyone, have a good night. Thanks for watching. Bye.